So, very good morning, everybody. Thank you very much for coming. I'd like to thank LRF to have given me this opportunity to talk more about marginal zone lymphoma. This morning, all of you got a brief overview of lymphomas, biopsying, imaging studies, why they are important, so on and so forth. We're now going to dig deep into marginal zone lymphoma. Some of this information may already be repetitive, but again, repetition is good. So in the middle, if you have any questions, please feel free to just raise your hand. I'm more than happy to hold off on my presentation and answer those questions. Alternatively, if you feel like you'd like to ask any questions towards the end of it, it's absolutely fine. So you did hear from Dr. Sen this morning that lymphoma is the most common blood cancer. At this point in time, we have about a total of 100 different subtypes of lymphomas. Lymphomas are basically a cancer of the lymph cells of your body. Lymph cells are like your Army Navy Air Force. They're supposed to protect you from infection and inflammation. There are switches that tell the lymph cells to grow, and there are switches that tell the lymph cells to die. In some patients, these switches become abnormal, and all the body gets is a switch to keep growing, as a result of which lymph cells They multiply abnormally, they form islands called lymph nodes in medical terminology. That's what you feel usually when you have the flu. But usually the lymph node that you get because of a flu is your body trying to actually fight it off. However, a lymph node that happens because of lymphoma usually does not regress or usually doesn't quite go down. There are other parts of the body which also are technically considered lymph tissue. For example, spleen is actually a giant lymph cell. Usually, it's important to know this because a lot of patients consider spleen to be very different than a lymphoma, lymph node. At the same time, your tonsils are basically your lymph nodes. Similarly, your bone marrow is part of the lymphatic system. Again, lymph cells are comprised of 3 types of cells. You can either have B cells, T cells, or NK cells. Whichever switches get abnormal, those are the lymphomas you get. For example, if the switch that triggers the B cell becomes deranged, you get a B cell lymphoma. Similarly, if the switch that triggers the T cell becomes deranged, you get a T cell lymphoma. So this slide is actually not meant to read, but it's basically helping you understand that there are nearly 100 types of lymphomas, as a result of which it's exceedingly important that we get to the biopsy and the diagnosis so that we know exactly what subtype you have. A lot of patients, especially patients with marginal zone lymphoma, are called CLL for maybe 5 years, 6 years, and then they get diagnosed with marginal zone lymphoma. As a result of which, I cannot highlight how important biopsies are. It may take a little bit longer to get you to your doctor's appointment because they are still working on your biopsy, but that is going to be very helpful in the long run, and that is something that is very pertinent to treating lymphomas. So if I was to break down these 100 different subtypes of lymphomas, I can say that the lymphoma is broadly divided into Hodgkin lymphoma and non-Hodgkin lymphoma. Non-Hodgkin lymphoma is further subdivided into 2 types. The first type is B-cell non-Hodgkin lymphoma, which makes up for 85% of patients. And the second subtype is T-cell non-Hodgkin lymphoma or NK cell Hodgkin lymphoma. They make up for only 10 to 15% of all lymphomas. B-cell non-Hodgkin lymphomas are again divided into 3 buckets. The first bucket is called aggressive. The second bucket is called indolent, or also called non-aggressive. And the third bucket is mixed non-Hodgkin lymphoma. Today's presentation, we are going to focus on the second bucket, which is the indolent non-Hodgkin lymphoma. There are about 10 different types of non-Hodgkin indolent lymphomas. One of the most common non-Hodgkin indolent lymphomas, rather the third most common non-Hodgkin indolent lymphoma, is a marginal zone lymphoma. So we're going to deep dive into marginal zone lymphoma for the remainder of the talk. It's important to basically highlight a general principle with respect to these 3 buckets. For example, patients with indolent lymphoma, and the examples of which could be follicular lymphoma, CLL, marginal zone lymphoma. Usually, patients are diagnosed incidentally, meaning sometimes they might not even have symptoms. They go to a doctor's office, they find that their white count is elevated. That basically triggers a barrage of testing, and that is how you get to your diagnosis. So a lot of times patients are surprised that they are feeling so good and they are diagnosed with a lymphoma. However, the biology of indolent lymphomas is rather slow. So they are very slow growing, usually. A lot of times they wax and wane. So sometimes marginal zone lymphomas can present with lymph nodes. And patients might come to my office and they sometimes tell me, you know what, this lymph node is actually going down on its own. We are just watching and waiting, but it's just going down on its own. Can that happen? And the answer is yes. Sometimes the waxing and waning feature can happen. But the baseline, it's important to understand that it's a chronic problem, meaning the philosophy or the goal of therapy is to treat when it's truly needed. Otherwise, you're not really trying to help the patient unless and until you are scared that the patient develops any symptoms or the patient comes in with symptoms. So a lot of times you might get the principle of therapy being watch and wait, and it's counterintuitive because in one breath I'm telling you have a blood cancer, and in the other breath I'm saying let's not do anything about it. But doing anything earlier than later so far has not really shown to achieve any change in outcomes. As a result of which treatments have to be thoughtful, they have to be given at the right time. There are a slew of options, and you can always talk to your physicians. It has to be a communication rather than a one-way street. For the most part, indolent lymphomas or marginal zone lymphomas are considered to be incurable diseases. So you live with that for the rest of your life. But it is certainly treatable. So the philosophy is pretty similar to high blood pressure. I'm not really trying to decrease the impact of the fact that this is a blood cancer, but it's important to remember that sometimes just watching and waiting and doing, lifestyle modifications is what people recommend for high blood pressure. But once you get on therapy, a lot of times you have to take that pill every day. That's the same philosophy for how we approach patients with indolent lymphomas. So with that being said, let's move on to how many cases of marginal zone lymphomas do we actually see. So to give you a rough understanding, we see roughly about 70,000 patients per year with non-Hodgkin lymphoma. And of those 70,000 patients with non-Hodgkin lymphoma, 8% of patients make up for marginal zone lymphoma. And that is reflective of even today's audience. So if you go into a session which has diffuse large B-cell lymphoma patients, there will be a lot more because by incidence, that lymphoma is 30% of all non-Hodgkin lymphomas. So at this point in time, there are not a lot of patients with marginal zone lymphoma, again, iterating the fact that it's important to seek attention or care at an academic center where there are lymphoma specialists, wherein all they see is lymphomas. It never hurts to get a second opinion. Moving forward, let's talk about a normal lymph node structure. How does a lymph node actually look? So whenever your doctor says we need a biopsy, we usually like to get the whole lymph node out. And the reason behind that is to understand the entire morphology of the specimen. On the right side of the cartoon, you can basically see how a lymph node looks. There are multiple follicles in there, and the yellow of the left side of the cartoon is what we call a germinal center. Around that is what we call a marginal zone. And when lymph cells around the marginal zone have their switches disturbed, that's when people get marginal zone lymphomas. So that is where it's really coming from. Now, marginal zone lymphomas are basically divided into 3 different subtypes. The most common subtype is extranodal marginal zone lymphoma. Extranodal means outside of the lymph node. So it's usually organs that get inflamed or affected with marginal zone lymphoma. For example, it could be the lung, it could be the eye, it could be the breast, sometimes it could be the stomach. That is extranodal marginal zone lymphoma. That is the most common of the 3 marginal zone lymphomas. It also goes by the word MALT, M-A-L-T, which is mucosa-associated lymphoid tissue. The second most common of the three subtypes is splenic marginal zone lymphoma. That is when patients have a large spleen. That is how they come to a doctor's attention because of symptoms that a large spleen can cause. The third subtype of marginal zone lymphoma is nodal marginal zone lymphoma. In this case, the organs usually are not affected, the spleen usually is not affected, but the patient comes to to a physician's office because they feel a lymph node. So that is a nodal marginal zone lymphoma. It is the least common subtype of the three subtypes of marginal zone lymphoma. So the biggest question patients ask me when I talk to them about lymphoma is, why did I get it? Did I do something wrong? Is this something that is because of an exposure to maybe a substance I was exposed to during my work? Maybe I've been a veteran. Is it because I served in the war? Well, there are certain causative agents that can cause lymphoma. But in marginal zone lymphoma, we know a lot more about what can cause marginal zone lymphoma. For example, chronic inflammation is a trigger for why patients can develop marginal zone lymphoma. For example, a lot of patients have what we call gastric marginal zone lymphoma or stomach marginal zone lymphoma. And most of the times, this happens because of a bacteria called H. pylori. So why does that happen? Usually any inflammation, for example, let's take, just for conversation's sake, say someone has chronic gastritis, meaning inflammation of the gastric wall. When you have chronic inflammation, it basically leads to the B cells of your body to start growing a lot. And at some point, they start growing more than normal, so it can become rogue. And when they become rogue, they become from singular to a lot of B cells. And every time there is a trigger, for example, the bacteria, the H. pylori is in there, it keeps shooting signals to the B cells to grow abnormally, till a point where the B cells actually start growing abnormally without even getting signals from the H. pylori bacteria. So a lot of times, marginal zone lymphoma, we really want to also look into causative agents that can cause marginal zone lymphoma. Therefore, in some marginal zone lymphomas, treating the agent can sometimes reverse marginal zone lymphoma. For example, there are multiple times when we look at a lot of chronic antigenic stimulation or chronic inflammation that can cause certain marginal zone lymphomas. For example, people who have a stomach marginal zone lymphoma, we do want to do an endoscopy, so an upper endoscopy, and we want to test for the H. pylori bacteria. Similarly, in patients who have a splenic marginal zone lymphoma, we look to make sure that the patient does not have hepatitis C, because a lot of times hepatitis C can cause splenic marginal zone lymphoma. Similarly, you can also have marginal zone lymphoma of the eye. And in some countries, especially for example in Italy, there is a higher predisposition of this bacteria called Chlamydia psittaci. And if someone has been exposed to that, if you treat the chlamydia, there has been shown to cause complete reversal of the ocular marginal zone lymphoma. There are two conditions which actually cause patients to be at a higher predisposition to developing marginal zone lymphoma. For example, patients who have any autoimmune conditions, for example, Sjogren's disease, or people who have Hashimoto's thyroiditis, they are at a higher chance of developing marginal zone lymphoma. As a result of which, detailed evaluation is a must when you are first seen by your oncologist. This is basically a picture that I have shown of different types of marginal zone lymphomas and what we can see. So on the left side of the cartoon, this is a gastric marginal zone lymphoma. This is the view that you see when you put in an endoscope and you look at it, and that's how your stomach looks if you have marginal zone lymphoma. So the white dot right there on the left side is basically marginal zone. On the left side below, that's the eye, which is the ocular marginal zone lymphoma. Sometimes you have nodules that appear on your conjunctiva. Sometimes it can be deep inside that it can cause pressure A sensation of pressure is sometimes patients how they present to the doctor's office. More evaluation leads them to find out that they actually have a mass sitting right there, and if you can biopsy it, that's how you get a diagnosis of marginal zone. The second middle cartoon is a splenic marginal zone lymphoma. So this is your large spleen, right there, here. So when you have a spleen that is that large, it can certainly cause symptoms, and I'm coming to what those symptoms will be. And on the right side of the cartoon, you have what we call nodal marginal zone lymphoma, which is multiple lymph nodes. It's almost like people who have follicular lymphoma presenting with multiple lymph nodes, but they usually don't have any organ involvement, like stomach or eye. So let's talk about individual clinical presentations. Usually the median age of having marginal zone lymphoma is in the 60s. If people have extranodal marginal zone lymphomas, that is usually seen predominantly more in females than in males. But that is not a rule. I have seen a lot of male patients who also have extranodal marginal zone lymphoma. So what are some of the telltale signs or some of the symptoms that basically warrant further workup? So heartburn, abdominal pain, that's just not responding to usual anti-reflux medicines. And that's what triggers an endoscopy. When you do an endoscopy, that's when you find specks of lymphoma cells, you take a biopsy, and that's how marginal zone lymphoma of the stomach gets diagnosed. Similarly, like I alluded to, if someone has ocular marginal zone lymphoma, they can have swelling of the eyelid. Sometimes their conjunctiva can look a little different. Sometimes they might have pressure behind the eyelid. That's the presenting symptom. In patients who have Sjogren's syndrome, sometimes they can have swollen salivary glands. They can come up with a swollen neck right here under the ear, and that's what triggers them to medical attention. Similarly, you can also have skin involvement with marginal zone lymphoma. So multiple papules or skin lesions can pop up on your skin, not causing you any problem. They are not itchy, they are not tender, but they're not just going away with everything you do. So they do biopsy, and that's how a skin marginal zone lymphoma gets diagnosed. Splenic marginal zone lymphoma is usually diagnosed because patients get symptomatic by the time they get to medical attention, because the spleen is basically a large giant lymph node that sits on the left side of your body right under the stomach. So when it starts getting enlarged, you end up having symptoms, for example, of a pulling, dragging sensation on the left side of your abdomen. The second symptom is every time you eat, you get full very fast. You have the appetite, but a couple of morsels in, and you don't want to do anything more. That's one of the other signs of splenic marginal zone lymphoma. Number 3, a lot of times, splenic marginal zone lymphoma also has patients who have high white count as a presentation. So they go to their routine physical, they get a white count, the white count is in the 20,000s, that leads to medical testing, then they do a CAT scan, and they find a giant spleen. Patients are not symptomatic, so there are times that even if you have splenic marginal zone lymphoma, you can actually be completely asymptomatic. So moving forward, if you do suspect marginal zone lymphoma, what will be the initial evaluation? Clearly, a good history and a physical examination is key. That's what your primary oncologist does. Subsequently, we send a lot of blood testing. The blood testing helps us understand, for example, is the white count elevated? Number 2, it helps us understand, is the hemoglobin or the red cells down? Are you anemic because of your lymphoma? Number 3, are your platelets, which are your cells that help clot your body, are those cells enough? Because you need them. Number 3, we also test for a marker called LDH. A lot of times LDH, also called lactate dehydrogenase, is a marker that is elevated if the lymphoma cells are growing very rapidly. I do want to also just express a word of caution here, because a lot of us now have access to our own medical information, which is fantastic. But that should not set off red flags because you see a red flag on your CBC, right? So every time you have an LDH, which is 400, wherein the normal has to be under 300, that should not trigger something that is, oh my God, I have never really heard this from my doctor. Am I progressing? Is this something bad? Usually we have to take the whole patient into consideration. Are you symptomatic is the first question we ask the patient. Usually LDHs in the higher range of normal can be expected even if somebody is not progressing. Of course, if your LDH is in the thousands, that's something that warrants medical attention. Similarly, we take a look at your kidney function. We want to make sure it's okay. We want to take a look at your liver numbers. We want to make sure they are okay. The other thing that we also see a lot in patients with marginal zone lymphoma is because it's a problem of the lymph cells produce antibodies. And sometimes you can leak abnormal amounts of antibodies. So for example, your IgG or IgM, your doctors may be testing that. That may be borderline elevated. We don't treat numbers, we treat patients. So you don't want someone to treat you just because a number is elevated. But the reason I bring it up is because if the IgG is elevated, a lot of times in patient marginal zone lymphoma, you do see patients who have a slightly abnormal limit of your IgM and your IgG. Let's talk about how to actually go forward with staging. We usually recommend a CAT scan. We do not recommend a PET scan for patients with marginal zone lymphoma, unless and until we are worried about a condition called transformation, which is when marginal zone lymphoma, which is a non-aggressive lymphoma, can sometimes switch to becoming an aggressive lymphoma. I'll talk about it in a little bit, but that is when a PET scan is very valuable, because that will allow us to know what is the hottest site on the scan so that we can biopsy it to understand if that site has converted to an aggressive form. Bone marrow biopsy is usually what I do recommend. However, in patients who have localized marginal zone lymphoma, say of the stomach, of the orbit, of the lung, in those cases, I think I am fine just skipping it. In terms of biopsy, I think Victor has sat on my presentations a lot, and I think he's heard this a ton. It's exceedingly important that you do allow your physicians to get the right sample. Having the right sampling will allow you to know what subtype of lymphoma you have of the 100 different subtypes. And why is it important? Because these are basically the 3 types of biopsies that can be done. The first one on the left side is something called FNA, which is a fine needle, which is a very tiny needle in and a tiny needle out. All you get to see is cells. The second one is a core biopsy, which is a slightly larger sample. That's when you get a better understanding. But the best way to really diagnose a lymphoma is an excisional biopsy. Of course, not jeopardizing anybody's condition if it is possible. For example, if it's a lymph node, I would like to take that lymph node out. On the other hand, if it is an ocular marginal zone, you just have to do a needle in and needle out, which is a core biopsy, so that you can get what best information you can get. So as you can see, based on the different types of biopsies, that's the information the pathologist gets to see under the microscope. So clearly, the most valuable analysis happens when you get a better biopsy sampling. Moving forward, why is this again important? Because it's important to understand a couple of things. When a pathologist takes a look at your lymphoma, they basically take a look at how it looks. For example, are they small cells? Are they large cells? Are they small and large cells? So a lot of times patients who have marginal zone lymphoma, they usually have small to medium lymphocytes. They don't usually have a lot of large cells. If they see a lot of large cells, then they may be worried that it could be an aggressive lymphoma and not a non-aggressive lymphoma. Then let's talk about what we call immunophenotyping. Immunophenotyping basically consists of flow cytometry and immunohistochemistry. Flow cytometry is when cells get placed through laser beams and then they get scanned for certain CD markers, which are basically proteins that you look for. And IHC or immunohistochemistry is what you're staining those proteins with. For example, IHC for marginal zone lymphoma has a very distinct subtype. They are usually CD20 positive. They are usually negative for other markers like CD5, CD10, CD23. Ki67 is a marker which tells us how fast or not the lymphoma cells are growing. Usually in patients with marginal zone lymphoma, the Ki67 is very, very low because it's a very slow growing lymphoma. And then, of course, there are what we call cytogenetics and FISH studies, which are basically DNA, RNA sampling. They are basically looking at further levels of detection of any chromosomal aberrations that can be found in patients with marginal zone lymphoma. For example, in gastric marginal zone lymphoma, we look for something called translocation 11-18. That is when there are two chromosomes, chromosome 11, chromosome 18, they are exchanging materials abnormally, because of which they are forming a protein that sometimes can make the gastric marginal zone lymphoma not responsive to therapy. So if initial treatment does not work for gastric marginal zone lymphoma, a lot of us look for this marker because that helps us understand why patients are not responding. Outside of that, really, we don't have any other marker that tells us what to do. However, it might aid in diagnosis. For example, nodal marginal zone lymphomas, we might see what we call trisomy 3 in nodal marginal zone lymphomas. But how does it help beyond diagnosis? I would say it doesn't have any impact on therapy yet. At the same time, in patients who have splenic marginal zone lymphoma, we definitely want to, if we are confused with the diagnosis, sometimes splenic marginal zone lymphoma, spleen is enlarged, but they can be enlarged in other subtypes of lymphomas as well. So there is something called deletion 7q, which is seen a lot often in patients with splenic marginal zone lymphoma. So these are tools that help us to distinguish between subtypes of lymphomas. Outside of 11-18, we usually don't use any other information currently to determine our therapeutic approaches. Moving forward, let's talk about the Ann Arbor staging. I know Dr. Sen touched upon it this morning. As you know, staging in lymphoma has very different ramifications than what a staging in a solid cancer will be. For example, patients who have stage 1 lung cancer versus stage 4 lung cancer, there are very different connotations to that staging. Lymphoma is a blood problem. Technically, blood is everywhere. Therefore, staging is more for the physician to understand where is he or she looking at hot spots, or where are we finding spots of lymphoma. A lot of times in patients who do have extranodal marginal zone lymphoma, particularly gastric marginal zone lymphoma, we also want our patients to undergo endoscopy. So upper endoscopy to look into the stomach lining, because it will help us understand how deep or not the lymphoma is going. Is it only in the superficial lining, or has it also percolated into the deeper layers? So a lot of times, people who have extranodal marginal zone lymphoma, they are diagnosed as stage 1 or stage 2. We usually do not see patients with stage 4 extranodal. When I talk about stage 4, I'm basically talking about a lot of organ involvement. So you have lymphoma in the lung, you have lymphoma in the stomach, you have lymphoma in the bone marrow, all at one time. That would be stage 4. However, usually what we see is one site is affected. That is usually stage 1. However, if the neighboring lymph node is affected, that is stage 2. There are times that in patients who have gastric marginal zone lymphoma, they can have multiple sites of affection all at the same time. On the other hand, when we look at splenic marginal zone lymphoma, patients who have splenic marginal zone lymphoma usually have bone marrow involvement. As a result of bone marrow involvement, that in itself becomes stage 4. But don't get overwhelmed by the staging in lymphoma, because that has a very different connotation than what somebody else with a solid tumor does. The third is, of course, nodal marginal zone lymphoma. A lot of times patients with nodal marginal zone lymphoma present with lymph nodes above as well as below the diaphragm. So usually they are in stage 3 or stage 4. It's very rare for nodal marginal zone lymphomas to present in stage 1 or 2. Moving forward, let's talk about prognostic tools. So what are these tools? These tools basically help us understand when a patient walks into our clinic, is he a low-risk patient or is he a high-risk patient? At this point in time, there are certain indices that we have looked into for patients with marginal zone lymphoma. For example, for splenic marginal zone lymphoma, there has been research that has been done wherein we have found that people who have anemia, so a hemoglobin less than 12, an LDH that's elevated, or an albumin that's less than 3.5, if somebody has all three factors, those are high-risk patients versus if somebody doesn't have any of the risk factors. Now, just be mindful that just because someone gets diagnosed with high-risk marginal zone lymphoma, we would not at this point in time treat them any differently. prognostic tools do not tell us how to treat patients differently than somebody with low-risk marginal zone lymphoma. However, it's helpful information because when a patient walks into my clinic, if I know that if he has gastric marginal zone lymphoma and if his LDH as well as stage doesn't make him high risk, at that point in time, it's an information that hopefully may be used for later.
So the abbreviation ALB is albumin?
Yes, so the question is the abbreviation ALB albumin? And the answer is yes. Yeah. So moving on to staging again, moving on to management. So let's talk about a brief overview before we deep dive into individual subtypes of marginal zone lymphoma. So usually the bottom line is treatment is driven by the site, where the site is. Number 2, how intensive or extensive it is. Number 3, if patients have symptoms. A lot of times in people who have extranodal marginal zone lymphoma, if you treat the organism with therapy, it can cause regression of marginal zone lymphoma. So treating the chronic antigen can cause regression of extranodal marginal zone. A lot of times patients only present with one lump, and all you need to do at that point is just do radiation therapy. Number 3 is rituximab, which is single-agent antibody. Rituximab was probably one of the first immunotherapy that was ever done in patients with lymphoma. It's been around for 2 decades. So each of us, and even including people who don't only do lymphomas, they have a lot of experience doing rituximab. Of course, the 4th option remains chemotherapy, but that is never the first option for somebody who gets diagnosed. Number 5 is for patients with splenic marginal zone lymphoma. Sometimes they do get offered the option of removing the entire spleen, also called splenectomy. And again, this option, which is the watchful waiting option, it's observation, it's called watchful waiting, it's called an expectant strategy. Like I had mentioned, it is counterintuitive. You come to a doctor's office to get help, hoping that he will start you on some medicine, and all he says is, well, let's watch it. But remember, watching something, if you don't have symptoms, if your labs are normal, does not harm a patient in the long run. As a result of which, if you get a therapeutic option from a physician, which is watchful waiting, and you truly don't have symptoms, I think it's a very reasonable strategy in patients with marginal zone. So because we're going to go into therapy, I just want to broadly touch upon rituximab. So rituximab is a monoclonal antibody. It basically sits on a protein called CD20, which is expressed on B cells, so normal B cells, as well as abnormal B cells, which are your lymphoma cells. And once they sit on the CD20, they basically do a lot of things. Number 1, they recruit immune cells to fight off the tumor. Sometimes they have the ability to also cause destruction of the cancer cells themselves. Now, outside of rituximab is almost 2 decades old now. We do have many other novel antibodies that are presently being used significantly in research, and they are showing more potency, more efficacy. So stay tuned for all those new antibodies. So let's deep dive into every subtype of lymphoma. So let's talk about the extranodal marginal zone lymphoma, also called MALT. So we talked about how chronic stimulation or chronic inflammation causes lymphoma formation. So for example, in patients who have gastric marginal zone lymphoma, if it is dependent on H. pylori, H. pylori is a bacteria that basically tells the T cells of your body to recruit more B cells. B cells become rogue, and that's how you get a lymphoma. So how do you treat gastric marginal zone lymphoma? I think the first question is, does that lymphoma tissue have H. pylori positive staining? If patients do have H. pylori positive gastric marginal zone lymphoma, then the treatment, surprisingly, is antibiotic therapy. You do antibiotics for 2 weeks, and the chance that you will respond is anywhere between 55 and 75%. And with this response, about 75% of patients remain disease-free 5 years after getting the antibiotic therapy. It's really nice to know that all you can give is an antibiotic and it causes regression of the lymphoma. So usually we could do the question is what antibiotic therapy is used. So as mentioned on the slide, it could be what we call a triple therapy or a quadruple therapy. Triple therapy could be a proton pump inhibitor like omeprazole or in combination with antibiotics such as amoxicillin. And you can give that doublet for a total of 14 days. On the other hand, the quadruple therapy consists of a proton pump inhibitor, bismuth, tetracycline, and metronidazole for a total of 14 days. Sometimes you may have to just repeat another course, and with that, you may still be able to get complete regression of a stomach marginal zone lymphoma. The biggest question is, once you take an antibiotic, how soon do you need to know and how soon can we know that the antibiotics have actually worked? And the answer is, usually it takes 3 months to take full effect. Therefore, a repeat endoscopy should not be done at least for another 3 months. So once that endoscopy is done, there are a couple of things that can happen. So you do an endoscopy, H. pylori is gone, marginal zone lymphoma is gone, and then you can observe the patient. Second, it could be H. pylori gone, but we may see specks of marginal zone lymphoma in there. In these times, I simply observe the patient because I know it might just take a little bit longer for the lymphoma to regress. The third option could be H. pylori is still positive, marginal zone lymphoma is gone. At that point, I give them a second course of antibiotics. However, despite doing antibiotic therapy, if H. pylori remains positive and marginal zone is also positive, it would be helpful to consider another line of antibiotic, or at that point you can also bring in radiation therapy. There are times that H. pylori is not positive and patients do have gastric marginal zone lymphoma. In these patients, there are two options. You could either radiate the area which is affected with marginal zone lymphoma. The response rate is 99% with that radiation. And the chance that patients will be disease-free at 10 years is over 70%. Number 3 option would be rituximab, the same antibody that we just talked about. You do weekly doses for a total of 4 or 6 weeks, and that is it. So within a month, you're done with therapy. The response rate, again, is upwards of 70%. So a lot of options exist. It's about making sure that you and your doctor do talk and discuss in terms of what remains the best option for you, your functional quality of life, and your understanding. So number 3 is, of course, when we talk about gastric marginal zone lymphoma, are there any other lymphomas that can be antigen driven? Yes. So there is a bacteria called Chlamydia psittaci, which is sometimes actually, you get exposed to it because of birds around you. It has been shown to be in higher predisposition in patients from Italy than in patients in the US. However, if you have an orbital marginal zone lymphoma, giving an antibiotic called doxycycline for 3 weeks has shown to cause responses in 40% of patients, which means 60% of patients may not quite respond to the antibiotic, at which point in time radiation therapy is actually very, very helpful. There are times when you see a lot of extranodal marginal zone lymphoma. So you not only see it in one area of the stomach, but maybe multiple areas of the stomach, versus not just in the stomach, but also in the lung, in the breast, maybe sometimes in the gut. When you have multiple areas, at that point in time, we don't usually go on radiating every spot. At that point in time, your doctor could talk about 2 strategies. Might talk about observation if you're not symptomatic at all, and I think it's very reasonable. Number 2 option would be rituximab. Again, the response rate would be 70%. When I talk about response rate, I'm talking about the chance that your lymphoma will shrink, whether it's by 50% or completely. The chance is at least 70%. Remember, the goal here is remission. So if you are intending to get to a remission, then radiating a single mass, or if there are multiple sites, then doing rituximab can get you in a remission. Management of extranodal lymphoma, this is what I do in my clinic. So if patients have gastric marginal zone lymphoma, I look to make sure the patient is not H. pylori positive. If the patient is, I give him or her antibiotic course. If they are not H. pylori positive, then I do either rituximab or radiation therapy after a thorough discussion of the pros and cons of the 2 therapies. therapies. If it is solitary marginal zone lymphoma, somebody has a lung spot or maybe a thyroid nodule. They biopsy, it turns out to be marginal zone lymphoma. I usually offer radiation therapy. If there are multiple spots everywhere, that's when I talk about either rituximab or observation. In very rare cases, I have talked about radiating the most bulky or the most symptomatic site in patients who may not be able to tolerate systemic therapies. Let's now go into splenic marginal zone lymphoma. So these are the classic cells that are seen under the microscope called villous lymphocytes. So these are basically large cells with a little bit of villi, or, they have small wings. And that's where you absolutely need to take a look at it, because hairy cell leukemia also kind of similarly looks like that. That is where your CD markers come into play, and marginal zone lymphoma expresses a distinct set of CD markers. So that is what helps us understand splenic marginal zone lymphoma. Like I had mentioned, in people with splenic marginal zone lymphoma, they usually have a large spleen. Their bone marrow is usually involved with lymphoma. White blood count is usually elevated. First thing to do is to make sure patients don't have hepatitis C, because if they do, treating the hepatitis C can cause regression of the lymphoma 2/3 of the times. So it's very important that we make sure that if you have hepatitis C, that treating it, and now we can actually cure hepatitis C with newer medicines, as a result of which it's very important to take a look at this virus. So to summarize, in terms of treatment options for marginal zone lymphomas, there are 3 treatment modalities. The first one is rituximab. You give it every week for either 4 or 6 times. Number 2 option, splenectomy. So take the spleen out. Number 3, observe. So in terms of rituximab therapy, the response rate is nearly 95 to 100%. The chance that you will go in a remission is very high just with rituximab therapy. Usually when we do that, even the spleen size shrinks nearly 90% of the times. A lot of times, if you go into remission, remember we are not talking cures here, meaning sometimes it is going to come back. And if it does, retreatment with rituximab also works in patients with marginal zone lymphoma. So just because you used rituximab frontline, that doesn't mean you have exhausted the option. A lot of patients worry that if I use it now, I may not be able to use it later, but actually you can use it later and you can also see responses. Yes?
Yeah, I've been using it every 2 or 3 months now for 2 years. And she says just continue on.
So the question is about maintenance, and I'll touch through maintenance in just a couple of minutes. The second option is splenectomy. Sometimes doctors recommend splenectomy. Now, if you remove the spleen, then that means it's a surgical procedure. Splenectomy usually does have a complication rate because any surgery has some sort of complications. I think in my mind, in people who undergo splenectomy or who have signed up for splenectomy, just remember you must get vaccinated before you take the spleen out. The spleen protects you from certain bacteria, and you want to make sure that you get vaccinated before you take the spleen out. In my practice, I have seen that if people have a lot of bone marrow involvement, removing the spleen usually doesn't help. It's usually treating patients systemically with rituximab that takes care of the spleen as well as the bone marrow. The times I have recommended a splenectomy is when patients do have a giant spleen, but for some reason their bone marrow doesn't have intense involvement with lymphoma. At that point in time, you can take off the spleen, in which case there has actually also been shown that some of the bone marrow changes might reverse. Observation, again, remains a very viable option for patients with asymptomatic marginal zone lymphoma. When we talk about asymptomatic, I'm really alluding to B symptoms or fatigue. So B symptoms are fevers, drenching night sweats, loss of weight, which is unintentionally, not trying to lose weight, but we are just losing weight. Intense fatigue, you're taking multiple naps in the day when you never really even needed one single nap during the day. Those are certain telltale signs that maybe your symptoms are driven by the lymphoma. So at that point in time, treating the lymphoma makes sense. However, if you're completely fine, not having any symptoms, the spleen size is not really bothering you in terms of how you are eating, it doesn't cause any fullness, in that that case, I think observation is something that I have recommended. And in my clinical practice now, I think I have been able to observe some patients even for about 3 or 4 years. So to summarize, management of splenic marginal zone lymphoma, first testing for the hepatitis C. If it is associated with hepatitis C, treat the hepatitis C. 2/3 of the time, the splenic marginal zone lymphoma will go into remission. If it is not hepatitis C associated, then your options are threefold: observation, rituximab, or splenectomy. Moving on to the third and the last one, which is nodal marginal zone lymphoma. Patients with nodal marginal zone lymphoma are not as common. They are the least common of marginal zone lymphomas. Usually, though, they present only with lymph nodes. They don't have a lot of organ involvement. So if they have one lymph nodal enlargement, I usually just radiate it, or sometimes I even watch it. If they have a lot of lymph nodes which are causing them trouble, then again the option is rituximab, usually. The third option, I think, in the systemic disease therapeutic options I have listed is rituximab plus chemotherapy. In patients who do have a lot of symptoms, wherein the lymph nodes are very bulky, in patients whose CBC or your complete blood count shows that you have a lot of anemia, your platelets are down, you're getting a lot of night sweats, there are times that your doctors might say that it is time to not only just do rituximab, but also combine it with chemotherapy. Usually the chemotherapy that's recommended is a less intensive chemotherapy, not the intensive chemotherapy. So less intensive chemo options are something like bendamustine. Bendamustine is a chemotherapy that can be recommended in certain cases of marginal zone lymphoma. So coming back to your question about maintenance therapy, meaning you initially treat patients with marginal zone lymphoma, they go into a remission, and then there are times that you do see patients in your clinic where their doctors have recommended that they be on maintenance antibody therapy every 2 months for a total of 2 years. Now, I can tell you that there is a lot of debate in this field with respect to maintenance therapy. We usually recommend something if it makes patients better in terms of symptoms or it improves survival of patients. Maintenance rituximab, based on the clinical trials that we have done, has shown to prolong your remission. So at this point in time, it will prolong the duration of remission, but it will not really translate into patients living longer. As a result of which, if remission matters, then in that case, maintenance therapy is helpful. But after a month of therapy, of the first line induction rituximab, if you go into remission, if you feel really good, if your functional quality of life is back to normal, you probably don't want to be tethered to a cancer center every 2 months for the remaining 2 years. So at this point in time, I think there is no consensus. There are doctors who strongly believe in maintenance rituximab. There are doctors who don't. In my opinion, it's a discussion. And based on what your goals are, I think that is what you probably go with. In terms of managing relapse disease, meaning you first treat patients with rituximab or you treat patients with radiation therapy and the lymphoma comes back. Remember, it's an indolent lymphoma, so there is a chance it can come back. And if it does, the options can be you can treat patients like the way they have been first treated. So maybe they had just radiation of one lymph node. There is another lymph node, just one lymph node that pops up when it relapses the second time. You might want to radiate it again versus you might just want to watch it if patients are doing fine. Number 2, they might be treated with rituximab previously and now the marginal zone lymphoma is back. It's very likely that retreating with rituximab will help you again. At the same time, we do run out of options. Kind of circling and kind of, trying to go over the 3 options that we talked about, which is observation, rituximab, and rituximab plus chemotherapy. That is where we do highly recommend clinical trials. So when a lymphoma comes back, I would recommend seeking options for newer therapies. Newer therapies, for example, maybe there is a newer antibody. For example, there is a newer antibody called ofatumumab or ublituximab. These are antibodies that are designed to hopefully be better rituximabs. You might want to look for clinical trials for those. Versus there might be immunotherapy. that might be a trial that might be ongoing for patients with relapsed marginal zone lymphoma. At this point in time, we don't have a lot of patients with marginal zone lymphoma, as a result of which we don't have clinical trials just geared towards marginal zone lymphomas. Therefore, a lot of times you might just find the terminology indolent non-Hodgkin lymphoma. So when you go on sites like clinicaltrials.gov, you might want to look into that verbiage that might allow you to understand which clinical trials might be of interest to you. So we talked briefly about transform lymphoma. Transform lymphoma is when a switch flips, we don't know why, but the marginal zone lymphoma becomes an aggressive lymphoma. At that point, you cannot quite treat them only with rituximab. You cannot quite treat them only with observation. You must treat them with chemotherapy. However, thankfully, the chance that that happens is very, very low. It's only 5 to maybe 8% a year, not more than that. And it's not cumulative, so it doesn't grow over a period of time. It's kind of there at diagnosis, sticks through therapy, and it's probably there even after that. How do we suspect if patients have transformed to an aggressive lymphoma? Usually patients have symptoms. They come to a doctor's office with a lot of symptoms, drenching night sweats, losing weight without really trying to do so. Lots of lymph nodes, bulky lymph nodes. When we say bulky, it's usually 5 centimeters, more than 5 centimeters. At the same time, maybe everything else is fine, but one side just grows like disproportionately. That's when your doctor might, always suspects a transform lymphoma. That is when a PET CT really helps, because a PET CT tells us how hot that lesion is, so that when we biopsy the hottest site, we can understand if it has transformed to a large cell or if it is still a marginal zone lymphoma. So let's talk about newer updates. And I think you will hear a lot of this in the immune therapy session. I'm just going to touch the surface of it. At this point in time, we talked about certain switches that have gone awry in patients with marginal zone lymphoma. Now, there are multiple switches that we are really working at. And which switch to really target? How do we target that switch? Should we target all these switches? If we target everything together, maybe it's a little bit more toxic. Maybe we might target one after the other in a sequential approach. So that is where clinical trials are really helpful. Coming to marginal zone lymphoma, we do have a deeper understanding, a little bit more than we had 5 years ago, about certain molecular or chromosomal changes that affect patients with marginal zone lymphoma that lead them to have a different signaling pathway that causes their cells to grow a lot more. For example, there is something called the NF-kappa B activation. This is a signaling pathway that in patients with extranodal marginal zone lymphoma gets upregulated. So it gets revved up a lot, as a result of which the B cells become abnormal, they don't quite die, and they are growing and they are proliferating. At the same time, in patients who don't have extramarginal zone lymphoma, but they have splenic or nodal marginal zone lymphoma, they might have the NF-kappa B activated, but because of other signaling. For example, maybe a mutation. For example, Notch mutations, KLF2 mutations. So that is where the lab science, so that is where we look for more molecular testing in patients with marginal zone lymphoma. So moving forward, we talked about these molecular pathways. So as you can see, this is basically a B cell receptor right there. So that one there. So the antigen basically sits on the B cell receptor and it triggers downstream pathways. In patients with lymphoma, these pathways are highly upregulated. So if we were to just focus on the BCR cascade, we now know that we can target that cascade with a lot of newer agents. For example, BTK is a Bruton's tyrosine kinase signaling that can be targeted or inhibited by a molecule called ibrutinib. Similarly, there's something called PI3K, which can be inhibited by a molecule called idelalisib. And then there is BCL2 right there, which is basically a pathway that if it is inhibited, you are telling the cancer cells to die. One of the most interesting agents is venetoclax. That is a BCL2 inhibitor. Now, this is a really old slide. It's probably now 3 years old. But having said that, there are multiple new molecules. There is a newer ibrutinib that just has been approved. There is a newer idelalisib that is in clinical research trials. And then there are multiple other BCL2 inhibitors that are in clinical trials. Similarly, there is a drug called lenalidomide, which is an immune modulator. So it not only affects the B cells, the T cells, it affects the whole microenvironment of the lymphoma tissue, and it causes decrease or regression of lymphoma. So lenalidomide is a pill. Ibrutinib is a pill. Similarly, all these molecules are basically pills. None of these are at present, yes?
You have a poor reaction to one of those drugs. Can you use another one?
You can. At the same time, there are various ways of actually mitigating the side effects. So there are certain side effects that can be expected from certain drugs. For example, if you get ibrutinib is a tablet that has now been recently FDA approved for patients with relapsed marginal zone lymphoma. In patients with ibrutinib, they can have about a 6% chance of having an abnormal heart rhythm. Similarly, the chance is rather low, but that's something that can happen. Number 2, they can be at a higher incidence of bleeding side effects because it does make the blood slightly thinner. Again, the chance is less than 10%, but you need to be mindful of it. At the same time, if somebody gets atrial fibrillation, which is an abnormal heart rate because of ibrutinib, if you treat it and then restart ibrutinib, you can actually take care of the patient rather well. So you don't always have to be completely stopping the agent just because you develop one side effect. Yes?
Do insurance companies readily cover some of these?
So that's a great question. So the economic ramifications of targeted agents are huge, as a result of which we absolutely need insurance authorization, as a result of which FDA approval is required. So if it's FDA approved, then technically there doesn't have to be a reason why patients have to pay a lot of out-of-pocket, but sometimes they fall into the donut hole, in which case the initial payments can be higher. But of course, there are multiple pharmaceutical companies that also do have multiple patient assistance programs, because of which all of this can be managed. Thankfully, I've not had a patient yet because even if it was approved, he never got it because it was too high. There has been pharmaceutical companies that have actually assisted with a lot of programs. So these are currently all the newer agents that have been tested in marginal zone lymphoma. Bortezomib is a pathway. It's an inhibitor that inhibits the NF-kappa B pathway. Lenalidomide we talked about. Of course, then if one agent works, then obviously you want to test if there is efficacy with combining these molecules with rituximab. Because remember, rituximab is an antibody that hits at CD20, which is positive in patients with marginal zone lymphoma. So if lenalidomide showed a response rate of 61%, then there was another trial where lenalidomide was combined with rituximab. And in which case, the complete remission rate, not just the overall response rate, the complete remission rate was 67%, which is rather striking. Idelalisib was also tested in this subtype of lymphoma. The overall response rate was 47%. I think the most important news that came for marginal zone lymphoma after a very long time of clinical trials is with ibrutinib. So patients with marginal zone lymphoma who relapsed after one line of therapy that contained rituximab, they were given ibrutinib. Now, the N is basically the number of patients that were treated on the clinical trial. So there were 63 patients that were treated. The overall response rate was about 50%. However, it's important to understand a little bit about these pathways, these cartoons. So on the left side, this is basically the overall response rate, which is split into what we call a partial remission and a complete remission. So when we treat patients, we want our patients to respond, but a lot of us want our patients to also respond fully. So that's called complete remission. Any response is probably a partial remission. So at this point in time, with ibrutinib, the chance that people will respond if they have failed one line of therapy is 48%. The chance they will respond completely is only 3%. Now that makes the molecule not look as good. However, take a look at what we call the waterfall plot. The waterfall plot is basically a plot that tells us how many patients responded and how many patients did not respond. So the waterfall plot on the right side of this picture basically tells us all the patients who do have these lines that are going down, that's one patient each. So everybody who responded, these are 48% of patients who responded. On the other hand, if you have anything that's going up, that means the tumor size is growing. So as you can see, this molecule is rather effective because most patients did respond. However, most of the responses were partial remissions. Of course, you want to better that. Of course, that's why clinical trials remain key. In terms of newer therapies, I'm kind of giving you a little bit of a lead into the next session, which is the immune checkpoint blockades. This is basically immunotherapy, wherein we are looking at manipulating the immune system. So on the left side, again, of this cartoon, you have the tumor cell and you have the T cell. T cell is basically your fighting cell. T cell expresses a protein called PD-1. Tumor cell expresses a protein called PD-L1. In patients with lymphoma, what the tumor cell does is it basically combines with the PD-1 and it hushes the T cell down. It tells the T cell, do not respond to us. Immune checkpoint inhibitors are basically inhibitors or targets or substances that are built to really bind to PD-1 and release that marriage. It breaks that bond, as a result of which the T cells are active again and they start doing what they are supposed to do. So one of this example is what we call PD-1 inhibitors, such as nivolumab and pembrolizumab. They have been tested in patients with marginal zone lymphoma, and in very brief phase 1 trials, they have shown responses. Again, clinical trials is key. Seek out for them if you do have relapsed marginal zone lymphoma. Of course, CAR T cell therapy, you'll hear a lot about that as well. It's basically taking your own T cells, manufacturing them in the lab, making them stronger, making them larger, making them multiple, and putting it back into your body to do what they are supposed to do. That is what I have told you, which is basically a 1-hour session. But CAR T cell therapy has really helped a lot of patients with aggressive lymphomas. In patients with marginal zone lymphomas, eventually I think we will be testing CAR T cell therapy, but right now just stay tuned for updates. So in terms of clinical trials, a lot of patients are slightly reticent about clinical trials because the first thing I get to hear, I don't want to be the experimental mouse. But at the same time, it's important to understand that we don't really do clinical trials without a lot of preclinical scientific data that supports it. The reason rituximab was approved for marginal zone lymphoma because there was a patient who signed up for a clinical trial. At the same time, ibrutinib is now an option because there were 60 patients who signed up for the clinical trial. Of course, there are multiple phases of clinical trials, and you will get to hear a lot more about what these phases mean. For example, phase 1 is when you're looking at the molecule and making sure it's safe, not causing a lot of side effects. Those are phase 1 trials. Phase 2 trials is basically to see if the molecule is not just safe, but is it also efficacious? Is it causing your lymphomas to regress? And phase 3 is when they get compared to standard drug. For example, I'm not aware of any phase 3 marginal zone lymphoma trial, but if I was to make up one right now, it would be a phase 3 trial comparing rituximab to rituximab plus something, or rituximab to maybe a completely new agent. That would be a phase 3 trial. So our goal as lymphoma physicians is to eventually step up to what we call personalized lymphoma therapy. We are probably not there just yet, but hopefully the effort is going to be placed into assessing tumors of individual patients. Not everybody hopefully will get the same therapy because everyone's tumor acts a little bit differently. And how do we know that information? We do have to do a lot of molecular testing. Once we get an idea of the aberrations or the abnormalities at a molecular level, then we hope that we target that patient's tumor with that particular aberration with a targeted inhibitor. Our goal as physicians is also to completely do away with chemotherapy. At some point, we hope to do this personalized lymphoma therapy approach in not just marginal zone lymphoma, but in probably all lymphomas. So, key questions to ask your doctor. Remember, you are your best advocates, so it's important to be well informed. You need to know what subtype of lymphoma you have. You need to first know, must ask a doctor, is my biopsy adequate or do I need to go through another biopsy? If you feel that the diagnosis hasn't quite been made, I'm willing to go through another biopsy because that will help you quite understand what subtype you have. Discuss with your doctor what are other treatment opportunities. Always seek what is your goal of a treatment option that has been offered to you. If it is observation, ask why. If it is radiation therapy, ask why. And based on those discussions, you will then choose what best fits your functional quality of life. I think I cannot underscore enough how important it is to seek out for clinical trials. You might be surprised that a clinical trial might be running just in another center in the same city, and you might want to be at least privy to the information. So, of course, please inquire about clinical trials. Clinicaltrials.gov is a fantastic site where you just have to put in your subtype of lymphoma and the whole clinical trial list pops up. Maybe it might be of interest to you. It never hurts to ask if I can see a lymphoma specialist, especially if you're being seen at a community center where the general hematologist not just sees lymphomas, but he also sees leukemias, myelomas. So it may not hurt to ask for a second opinion from a lymphoma specialist. More information never hurts. So with that said, I'm going to conclude the talk and say that the field is evolving. Stay tuned for updates. I cannot thank you enough for coming to California for the LRF Forum. I hope to have educated you a little bit more about marginal zone lymphoma today. I can say that huge advances are coming, especially with non-chemotherapeutic approaches. We are talking pills. We are talking non-chemotherapy agents. So the field is clearly growing. We are hoping to target the Achilles heel of these cancers and hoping that every patient gets the personalized therapy that he or she deserves. So with that said, I am open to questions.